Assalamu alaikum, Masal Khair, good evening. My name is Ibrahim Swaih, I'm a neurosurgeon, and we are transmitting live to our international audience from the Farah Medical Campus here in Amman, Jordan. The topic for tonight is going to be recurrent carniopharyngiomas. We spoke about carniopharyngiomas in the past, now we will concentrate on recurrence, and this is a picture of these ugly tumors. The pituitary gland, when it forms from a process that comes from the pharynx, another process that comes from the brain. They meet together and they form the pituitary gland. So we have a process from the pharynx and the cranium. That's why it's called carniopharyngioma. That happens in the 6 weeks of gestation. So here they are meeting, they form the anterior pituitary. Anterior pituitary comes from the pharynx part, and this comes the neurohypophysis comes from the brain part. And this meeting here, the patch, if it persists, it can form carniopharyngioma. So the carniopharyngioma can be within the cella, supracellular, or completely within the third ventricle. So here we are, cellular, 5 to 10%. The supracellular is the majority, 80 to 85. So here it is just occupying the cellular and supracellular, pushing the chiasm up, or here it's going above the chiasm, or here it is going invaginating the floor of the third ventricle. Here is completely within the third ventricle. So 5%, 5%, and about 90% is the supracellular part. To deal with these lesions, you have to be absolutely sure about the anatomical knowledge. It is a crime for any neurosurgeon or resident to go there if he doesn't have the full knowledge of every structure there. And I usually ask, how many of our neurosurgeons and our residents know this anatomy? The answer is extremely very few. So all this relationship with the pituitary gland, with the carotids, with the posterior cerebral, the third oculomotor nerve, and the anterior communicating complex is very essential. And also, another essential is the anatomy of the third ventricle, which is made of a roof, posterior wall, floor, and the anterior wall. So this is the anterior wall, which is the lamina terminalis. The roof is made by the body of the fornix. Underneath it is the choroid plexus and the internal cerebral veins. The posterior wall is made of this structure here, the junction of the internal cerebral veins to the vein of Galen, and the bottom is the pineal gland. And the lateral wall of the third ventricle, part of it is related to the thalamus, and part of it is related to the hypothalamus. The floor is the hypothalamus, made of many structures, but here we can see the mammillary bodies. And this hypothalamus, as we said, it's the 5 grams that control the essence of our life. Just 5 grams of brain tissue controls you fully, from the time of birth, from the time of development in utero, till you die. This is the responsibility of the hypothalamus. So it attained great importance to know the nuclei within the hypothalamus, and we found that they are arranged in the groups, medial group and lateral group, and from anterior to posterior, anterior, medial, and posterior group. And each nucleus, what it is responsible for. This physiological knowledge is mandatory for anybody operating in that area. And another structure that needs to be addressed is the liliquous membrane, which is made of the diencephalic leaf and the mesencephalic leaf. So any lesion within that area, of course, may have a vast differential diagnosis. These are carniopharyngiomas. These are all my cases. You can see the cellular supracellular area, But also we have to address that there you will have pituitary adenomas, especially if they are aggressive, like these cases of mine, or the Rathke's cleft pouch, which is the same like a craniopharyngiomas. They have the same developmental changes, they have the same developmental basis. Meningiomas in the supracellular area. Again, these are my cases. Cellular meningioma, supracellular meningioma. Epidermoid in that area looks like pituitary apoplexy or looks like a craniopharyngioma. Why should we know this? We just operate on these lesions and then find out. Wrong. You have to know them before you operate so that you are prepared of what to do, what are the expectations. You tell the patient, the relatives, what are the outcome, what's the prognosis. But people do not want to know. They just want to operate with little knowledge, and they just take a biopsy and send for radiotherapy. One case of mine also is the hypothalamic hamartomas. I think we'll address this in another future lecture. Germinomas, histiocytic sarcoma, teratoma, histiocytosis supracellular. The largest optic glioma in literature, it's mine. Astrocytoma, lymphoma, chordoma, plasmacytoma, sinonasal carcinoma, metastasis, sarcoidosis, aneurysm in that area. All these, they are included in the differential diagnosis. And they should be thought, and they should be in your mind whenever you see a patient like this. Osteoma, choroid plexus villoma, which we presented last time, oligodendroglioma, arachnoid cysts, anesthesia of neuroblastoma. So it's a wide differential diagnosis. Dr. Hadid, did you want to comment?
Do we have just to comment about
the differential diagnosis? Yeah. Yes.
About the imaging. The craniopharyngioma has a variable imaging. You can't, but you have to remember it has two types: the adamantinomatosis type and the papilla. The adamantinomatosis type, it is A. You gave it A grades. 90% calcified, 90% cystic, 90% enhanced. Okay, this is usually comes in early age group. While the papillary, it is rarely calcified, mostly solid, it is enhanced. As we said, diffusion restriction, there is no diffusion restriction on the craniopharyngioma because it is benign. Thank you.
The word benign in neurosurgery does not mean much. It's a histological definition. But a benign craniopharyngioma being situated in this malignant situation is very difficult. Any other radiology comments? Okay. What's the management of these? Treatment modalities available. Either you do the surgery or you treat them with radionuclide, chemotherapy, radiotherapy, and conventional radiotherapy or radiosurgery. These are the modalities that we have in hand. Whatever the mode of treatment, be it by radiation or by surgery or by whatever, it needs a dedicated team. Neurosurgeon, anesthetist, neurologist, endocrinologist, ophthalmologist, neuroradiologist, neuropathologist, and radiation oncologist. Last time, I think we presented this case downstairs, Dr. Hamad Jum'a told you about the management of DI in these patients, and Dr. Waishid also described the anesthetic risks of these patients. It needs common knowledge. We are one chain and we help each other. Surgery, various routes: transcortical, transcallosal, subfrontal, frontotemporal, transbasal, transpetrosal, transsphenoidal, and so on. Of course, that's surgery and that's endoscopy. Surgery, two groups of people: the good ones and the not good ones. The good ones believe in radical resection. The not good ones believe in partial resection and radiotherapy. I do not subscribe to this. I subscribe to this because this is less recurrence, less procedures, and good quality of life. Here, higher recurrence, multiple procedures, complications of radiation, quality of life is poor. So it is the state of mind when you operate on these patients. Before you start surgery, am I going to do radical excision or partial excision? Those good people, they would go for radical. Those not good people will go for biopsy and radiotherapy. There is always a border that can be identified, most of the time, 99%. So the traditional teaching to the residents by their mentors is wrong. It's a crime to tell the residents that these tumors cannot be removed. Don't try, they cannot be removed. This belongs to the medieval ages. Neurosurgical experience has an impact on the extent of resection. If you are a good surgeon, you will achieve good excision. It's a very simple formula. Good surgeons do radical excision. Is it me that I'm saying this? No. If you recording this session, you can magnify these and see the names of the great giants who are doing radical excision of these tumors. I'm not going to dwell on that, but just to tell you that there are so many good neurosurgeons that are doing the right thing, and very few mediocre surgeons that they are doing the crimes. Let's just go through them. Harold Hoffman is recognized as the father of pediatric neurosurgery in the world. He is from the University of Toronto. 1977, radical excision of recurrent 1977. They did not have the advantage of MRI, they did not have the advantage of anything, but they realized this. 1990, Muhammad Ghazi Ezerjil, the man of century of neurosurgery, radical excision in 144 patients. Of course, as I said, he's a friend of ours. 1994, this is mentioned in all books. We advocate radical resection as the optional treatment in all patients, pediatric or adults, especially for children, because you don't want to radiate a child. And listen to this, incomplete resection is a virtual guarantee of recurrence, 100%. Is it only to the Western world? No, Japan, 2005, this man from Japan says, I do first surgery, if they recur, I do second surgery, I do third surgery, not for radiotherapy. Because you are in a very important structure, which is the hypothalamus and the optic apparatus in a child. Argentina, 2005, radical resection of the carniopharyngiomas. Oh, it's big, it's adherent. Nonsense. This teaching must stop. Those mediocre mentors, they should disappear from our world, telling the residents that it is impossible to remove a carniopharyngioma. USA, 2005, total resection proved the best outcome. What happened to the hypothalamus? Oh, you will damage the hypothalamus. Nonsense. You will damage the hypothalamus by giving radiation, by keeping the tumor there. Sam al-Mifti, giant of neurosurgery, Syrian living in the States, total removal, 2007. Look at this size. Kirsten Saint-Jean, Saint-Rose, French, was also a leading pediatric neurosurgeon. The best overall results is achieved by complete resection by experienced carniopharyngioma surgeons. If he cannot, then subtotal resection followed by radiotherapy. But he is experienced. He is going there with a state of mind, I want to remove every ion of this. If this experienced surgeon failed when he is trying to remove it completely, you have to accept defeat and then do subtotal resection and radiotherapy. Efficacy and safety of radical resection, USA 2007, by Wissoff. Another giant of carniopharyngioma is Farbusch, Rudolf Farbusch, from Erlangen in Germany. Complete carniopharyngioma resection with acceptable morbidity can be obtained in 80 to 90% of cases. These are giants of people, not me telling you this. China, 2008, radical resection. China, 2008 again, radical resection. And then comes this paper by Pascal from Argentina. He's a close friend of mine, and we always, in the same session on craniofaryngiomas, he produced this paper. He says, the tumor would displace the mammillary bodies. So when you remove it completely, you will not damage the mammillary bodies and you will not damage the hypothalamus. So that was a real tool showing how the mammillary bodies would move. So by doing radical excision, you take the tumor out of this brain, keep it healthy, and you don't subject the patient to radiation. Question from Korea, 2015. Is complete resection feasible? The answer is yes, yes. You can achieve total radical excision. You just need to know anatomy, pathology, physiology. Go and train yourself. Those people who do not want to learn, those people who finish the board and they just go for service, they would never do a good case of craniofaryngiomas. And their monitors also. Majid Sami, giant of neurosurgery from Hanover, 65 cases of giant craniofaryngiomas, gross total resection in majority of them. Another giant of pituitary craniofaryngioma is Ed Laws from Harvard. He's now in Harvard, actually. He was the president of the World Federation and the president of the American Surgeons. And what he says, unfortunately, non-surgical options have provided limited benefits while incurring their own risks. Non-surgical options should be reserved as adjuvant therapy following surgical management. The best long-term outcome is reported following gross total resection. Don't believe me, believe him. Mayo Clinic, 2018. Craniofaryngiomas as a primer for the skull-based surgeon. It is in the domain of a good neurosurgeon to do radical excision. Asian Neurojournal, Neurosurgical Journal 2018, radical resection. So don't listen to those mediocre surgeons, those mediocre mentors, and those mediocre residents. Mayo Clinic, maximum safe resection by microscopy or endoscopy provides very good tumor control. What do we see in terms of bad practice in surgery? Is the insertion of Ommaya reservoir. This is still practiced every day in Jordan and the Arab world and the Islamic world and the third world country. This is a crime. It has finished a long time ago. Nobody uses Ommaya reservoir, yet the mentors teach their residents this is the way to do it because it's easy. Who is Ommaya? Ommaya is a Pakistani neurosurgeon who immigrated to the United States. He was actually in Oxford and then he went to the United States. And in 1965, he was working in the States and they were wondering how to put some chemotherapeutic agents into the ventricles for the cancer patients. And he came up with this tube. You put it in the ventricle, you inject the antibiotic or the chemotherapy or whatever into the ventricle. So when he invented it, he invented for access to the ventricles. It turned out to be the only weapon in the hands of mediocre surgeons. Look at this. What would you do with this? Oh, we evacuate the cysts every week. Look at this. And this paper from Brazil, cortical seeding of a craniofaryngioma across. Look at this. It's seeded. Intracranial ectopic recurrence of craniofaryngiomas after Ommaya reservoir. This is the thing, and this is Ommaya reservoir. You have done nothing. And you go and bring the patient to and fro, and the tube is blocked, and meningitis, and so on. And they live with it. I don't know how they live with it. Look, listen to this. Mayo Clinic, I hope you will believe this. Ommaya reservoir is a palliative and it is used in resistant cases only and should never be considered as a first line treatment. Never. Another bad practice. Carniopharyngiomas causing hydrocephalus. What's the treatment? Shunt. Because shunt is the first surgery that the resident in the Arab world and the underdeveloped world knows. So he has to do shunt. It is the only surgery he can do. Berholt, what's a dural? A disc, screw for fixation. These are the 4 surgeries that they can do. And they remain all their lives depending on these 4 cases. Shunt, look at this. What is shunt going to do? It's wrong shunt, wrong path. Look. Very bad practice, bilateral. Why? Because the carniopharyngioma has blocked both ventricles. So what they do? Bilateral shunt. And we put U-tube, UI connection, and that's it. And send for radiotherapy. Look at this. Whenever there is a preoperative MRI, they usually produce postoperative CT scan, never postoperative MRI. And they call this recurrence. Is this recurrence? This is incomplete excision. But this is called recurrence, even by a radiologist. Our patient had previous surgery, now he has recurrence. It is not recurrence. Tell the world the truth. Tell that this surgeon is bad, he's a mediocre. This is a tumor as it was, and no more. The other mode of treatment is by endoscopy. And look at these pictures by endoscopy. Endoscopy is the future of a neurosurgery. It gives you information. It actually taught me personally a new anatomy. This is the chiasm as seen from below, from the nose. Chiasm, optic nerve on the left, optic nerve on the right, the pituitary tube, the blood vessels, the inferior hypophyseal artery, superior hypophyseal artery, anterior communicating complex. Beautiful anatomy. Optic chiasm, pituitary tube. Again, look at the anatomy here. And here, excision of carniopharyngioma by endoscopy. This is the inside of the third ventricle. And this is how it goes. 2007, approaches of carniopharyngioma. This was done by Enrico De Vitis and Paolo Capabianca from Italy. They are the giants of endoscopy, neurosurgical endoscopy. Amin Kassam from Pittsburgh, again, made this classification according to the findings of endoscopy. Another paper from Gardner and Snyderman from School of Medicine of Pittsburgh, Pennsylvania. You can see the before and after via endoscopy. So whether you are doing it microsurgery or doing it endoscopy, the aim is radical excision. Italy 2004. This is Giorgio Frank, again from Italy. We served together in one of the committees of the World Federation. He's a great endoscopist. Fred Gentili, my friend from Toronto. He can actually do it microsurgical and endoscopy. He's a great man. And you can see the results. The other mode of treatment is the intracystic radionuclides, bleomycin, yttrium, uram, B-emitting radionuclide, B32, rhenium, interferon, etc. Are they good? No. And this is a final statement in this paper by Winke in 2012. He says, his group says, searching the multiple databases, relevant articles. So databases, articles, reviews, conference proceedings, ongoing trial databases, we are unable to promote treatment with intracystic bleomycin in children, period. Still people still using it. Oh, interferon, a new thing, let's use it. There you are. What's the result? The tumor is still there. After 3 years, the 2 years of treatment. Another paper from Japan about the intracystic things. Look at this, and 2 months later, what have you achieved? Disaster. From China, they speak to you about the treatment with phosphorus 32, and how many times the treatment? Once, twice, thrice, 4 times. The leak of the medicine outside, meningitis, brain damage, you know it. And this is another statement. This radionuclide should not be given for any patient expected to go for surgery, because if you give and then refer for surgery, surgery is not going to work at all. What about radiotherapy? Radiotherapy or radiosurgery, the same. They have their own complications. And this is a picture of one patient of mine whom I operated, removing his craniopharyngioma for good reason or for bad reason. Somebody in his own country gave him radiotherapy, and you can see the necrosis, temporal necrosis and brainstem necrosis. We're talking about child. Types of radiotherapy: external beam radiation. This is the abbreviation. Conformal 3D radiotherapy, intensity modulated radiotherapy, IMRT, proton beam radiotherapy, stereotactic radiosurgery, and brachytherapy are the same radiotherapy. So to speak about stereotactic radiosurgery is wrong. This is stereotactic radiotherapy. It has nothing to do with surgery, and those people doing it are not surgeons. So radiotherapy or radiosurgery carry this vast risk. But it's useful to use it in cases when you have failed. And this is really the end of it, so the end of the line. Harvard, 2006, using combined methods of radiation to treat these craniopharyngiomas. Usually they are recurrent after many surgeries. And another paper treated by radiotherapy, 97 patients. And this paper, I think, comes from Memphis, Tennessee, in this period of time. And these are the lists of the patients. Another paper about proton beam therapy from Texas, Houston. And they could not find any difference between their various methods. Another paper from USA using dosimetric kind of assessment between MRT or proton beam and MRT radiotherapy, and the treatment is almost the same. Advances the management of craniopharyngioma by radiation. So radiation is developing, but it is not the first line of treatment. It is not the main line of treatment. It comes third, fourth, fifth line of treatment. Gamma knife, story of the gamma knife, which I am never going to stop until people realize what's happening. This is from Charlottesville, Virginia, and it's one of the major radiosurgery centers in the world, in America. Steiner was there, Laszlo Steiner, God bless his soul. He started all this, he was a very good man. And these people are treating this with gamma knife. They forgot that gamma knife should not be used in any tumor which is adherent to the optic apparatus. They just forgot about this. And I always refer to my lecture here when we brought the gamma knife, so I know what a gamma knife is. Limitations are variable, and we discussed the malignancy last time. Still, people are using the stereotactic radiosurgery. It's said to be called stereotactic radiotherapy, not radiosurgery. There is no surgery in it. 1 year. 1 year after, what's the difference? Oh, we have controlled the tumor. They say, control. What do you mean by control? Gamma knife, 2005, 98 patients. Look at the difference before and after. Control. So, when this, and this is the topic for tonight, when these tumors recur, they can recur in the same sites or they can on the other sides. But remember, recurrence, you should have had complete resection proven on MRI before you say it's recurrence. So stop saying recurrent when it is actually residual and incomplete surgery by mediocre surgeons. But also they can occur in other sites far away from site of surgery. This paper, also ectopic, recurrent, I choose to put this as the first paper on these recurrences, 2019. This is published in World of Neurosurgery recently from China, and they speak about this. See, Carniopharyngiomas, and then this is the recurrence in the temporal area. So this is original, this is the seedling or recurrence. And they have put a long list of recurrences. This is the cases, and these are the authors. Again, anybody who is recording this can see for themselves that this is true. And they can occur anywhere: frontal lobe, Sylvian fissure, cerebellopontine angle, prepontine, interhemispheric, everywhere. From South Korea, this tumor, removed it, look what is the recurrence. So this is the true word of recurrence. They have removed it. This is the evidence, and it recurred. But if you see this as a pre-op and see that there's still a tumor there, this is not recurrence. Another ectopic, again from the group of Valleycrest and Little Rock, Arkansas, and you can see what is the seedling. The brainstem, the thalamus, everywhere. Ali is from Lebanon, he works in Little Rock. From Germany, this tumor, and this is the recurrence. Finland, this is the tumor removed, this is the recurrence. Sweden, 9 years after surgery, there is a frontal recurrence, frontotemporal. Another paper in the Journal of Pediatric Hematology Oncology from USA, 17 years after initial presentation. That calls for a close follow-up. You have to follow every case of brain tumors for many, many years. Every brain tumor of mine must have a brain MRI immediately after surgery, every 3 months for 1 year, every 6 months for 2 years, and then every year thereafter. This tells you this: 17 years after the initial presentation, they have recurrence. Subgaleal recurrence. And this paper, 2014, tumor and the recurrence. Recurrence in Sylvian fissure from USA. Recurrence from Spain. Impact of a tumor topography. Very beautiful paper telling you the relationship of the optic chiasm of the tumor and the anterior complex in relation to would you be able to remove the tumor completely or not, like the paper of Pascal. Again, ectopic recurrence of carniopharyngiomas along the surgical tract. They have removed it, it's recurred along the tract. From China, ectopic recurrence, frontal, and brainstem. Early ectopic recurrence of carniopharyngiomas, CP angle. Recurrence, frontal. So, what is the histology of these recurrent cases? Are they the same like fresh carniopharyngiomas? For this, Dr. Hassan Fonseca will tell you if there is any difference between the fresh cases or recurrent cases.
Assalamu alaikum. This is one of the recurrent gross cases. You can see they are in multiple cystic areas and solid areas. And this is the squamous part of the carniopharyngoma. You can see carniopharyngoma that is adenoma-tomatous type. Usually have many wet bodies, we call them. This is the basal layer, and this is the stellate reticulum, and this is the superficial layer, and this is brain tissue or gliosis around it. The recurrent cases we found there are actually many gliosis, more gliosis, because it's obvious because they are recurring in glial tissue. We can see again the higher power. This is the basal layer, and it's different from the stellate reticulum and from the superficial layer and with keratin. And we move these are different actually. You can see carniopharyngoma has a lot of calcification, as in this case. This is calcification. Sometimes you can have foreign body giant cell reaction secondary to the keratin. And this is the basal layer with keratin and the superficial layer. Again, you can see calcification, and this is the foreign body giant cell reaction surrounding the calcified areas. This is part of the wet keratin areas. This is the stellate reticulum. So squamous cells, actually, they have 4 different patterns in a craniopharyngioma. Again, this is the calcified areas with foreign body giant cell reaction with the gliosis. A lot of gliosis in this case. This is HND. This is again, you can see there is wet keratin and basal layer singles and stellate reticulum. This is one of the immune staining. I think this is cytokeratin 19. You can see cytokeratin 19 always we found it strongly positive in all layers of craniopharyngioma. The stellate reticulum, except the wet keratin, is negative. The basal layer, stellate reticulum, and the superficial layer. And we found cytokeratin 19 positive in all cystic lesions in the brain. And this is really was very interesting, and we had an abstract on this one. This is cytokeratin 19. You can see it positive in the basal layer, positive in the stellate reticulum, and positive in the superficial layer. So it's positive in all layers. And I mentioned to you earlier that cytokeratin 19 is really one of the very early cytokeratins that are present in the intermediate, the interim cells in the embryo, in the squamous cells. So probably this is why I explained it's present in all the cystic lesions, probably because they have some congenital etiology in this. Epithelial membrane antigen, on the contrary, is not present in all layers. It's present on the surface layer and in the wet keratin, but it's not present in the stellate reticulum or in the basal layer. Although it's epithelium, called epithelial membrane antigen, but it's not present in all epithelial areas. Again, you can see epithelial membrane antigen, how very beautifully illustrated in the luminal area and in the wet keratin, but it's negative in the stellate reticulum and in the basal layer. GFAP, as it's a stain for the gliosis or brain tissue, is very strongly positive in between the squamous cells. You can see the gliosis is very prominent. This is the area of the gliosis and in between squamous cells. And this is probably what characterized the recurrent cases, that they have more gliosis surrounding them. High molecular weight cytokeratin, it's present in all layers of the squamous, except in the wet keratin, as you could see. By the way, you mentioned, you can see that I discriminate between the 4 layers of squamous layers because we really did a big study, and we published this, we presented in Orlando CAB, College of American Pathologists, in 2013, and also we published this. Me and Dr. Ibrahim Sbih will show you later. Because it's obvious that the cytokeratin or the different layers of craniopharyngioma, they really have different pathogenesis and etiologies, and they are not all the same. And that's why probably, like, for example, wet keratin is not present in papillary type craniopharyngioma. It's only present in the adamantomatous type. Low molecular weight cytokeratin is present in the stellate reticulum. You can see it's negative in the basal layer. B63, it's a squamous marker. Sometimes it's negative, but sometimes it's positive. Here you can see positivity in the stellate reticulum and in the basal layer. K67 usually is low in craniopharyngiomas, even in the recurrent cases. So K67 really does not indicate much of a prognostic value. You can see some positivity. Usually it's less than 1%, but we do it because it's routine to do in all brain tumors, but it doesn't really help in differentiating whether this is going to recur or not. This is the paper that we really published, me and Dr. Ibrahim Sbih, in International Clinical Pathology Journal, about different keratin or different epithelial markers that are present in different layers of the squamous cells. And not every squamous marker will be positive in different craniopharyngioma, and it probably will help in the pathogenesis and etiology of these cases, and maybe in the future will help in predicting some recurrences if somebody wants to study it further. This is the paper. And this is the abstract that we, poster that we presented in 2013 in College of American Pathologists. Thank you.
Again, here you can see, please, طبعا.
How can you explain ectopic dissemination? Is it by spreading through of cancer cells or tumorous cells through blood vessels to the ectopic place?
No,
and if it is the case, do you expect to find ectopic tissue in other, not in the brain, skeletal?
Sure. All the distant seedlings were along the CSF pathways. So whenever any tumor, benign or malignant, comes in touch with the CSF, then it can metastasize into the subarachnoid space, into the posterior fossa inferior. So there is no metastasis outside the brain from craniofaryngiomas. It is through the CSF. Any comment or any? Please.
The craniofaryngiomas can be outside the cranial cavity. The craniofaryngiomas can be outside the cavity. It can be in the paranasal sinuses, and it can be in the nasopharynx.
Because it goes again through the CSF, through the endonasal approach. The question,
as a primer, not as a metastasis.
It usually is having this connection. As we said, craniofaryngiomas comes from the pharynx up, so it can be. Embryologically is there. Can they turn malignant? Of course. So we have to stop thinking of craniofaryngiomas as benign. We have to stop thinking of meningioma as benign. In the brain, there's nothing called benign. All are aggressive, all can be fatal if you don't treat them well. So they can turn malignant, and this is histologically proven. Leave them there for a long time, like the theory of any tumors. Chronicity is one of the causes of tumors. So any tumor that you leave, observe, control, it will turn malignant. Malignant, 23 cases in literature. Again, malignant craniofaryngiomas from USA. So I'll come now to the personal series of mine about craniofaryngiomas in general, about recurrent cases. Are they common? They're not. In USA, which is about 350 million now, you get 120 cases per year for the whole of the United States. So an average neurosurgeon will operate, maybe or may be able to operate on one craniofaryngioma every 2 to 3 years. So anybody who has a collection of 20 or 30 is lucky. I was the luckiest of all. I have 102 cases because I accept the challenge of treating these cases that are referred to me from the Arab world. Mostly in children, and the disaster is that they have giant size. Solid, 38. Mixed, 52. Simple cystic, 13. Size of 4 or above 4 is 74. And here they are. These are real giant craniofaryngiomas. That's why I have this collection, because I accept to take the risk and the challenge of treating these cases, not to be a mediocre man, mediocre surgeon doing biopsy and radiotherapy. For all patients, we do ophthalmological assessment, pre and post-op, including everything. Visual acuity, color, fundoscopy, visual fields, and optic OCT. And this is an example of before treatment and after treatment, where the visual fields opened. And we use the German way of assessing visual fields and acuity. We also do the psychoanalysis, especially for kids and adults. And because you are operating in the anterior communicating complex and the hypothalamus, and you need to do the Karnofsky performance scale. Surgery, for these cases, you can use, I use different methods, but I love either the diurnal approach or the transbasal approach. Look at this. Optic nerve, nerve chiasm, tract to tract, and the tumor presenting itself through the lamina terminalis. And at the end, you can see the liquid membrane, and you can see the basilar artery, and you have preserved the pituitary stalk. Do we preserve the pituitary stalk in all cases? I do my best. But if the pituitary stalk is tumorous, I do not hesitate for a second in excising it. The largest craniopharyngioma ever, Hiroshima and Nagasaki of craniopharyngiomas. 5-year-old with this tumor extending from the floor of the fourth till foramen magnum. All this. Huge tumor before and after surgery. Oh, you damage the hypothalamus. No, you damage the hypothalamus because you are ignorant. Because you will do small biopsy and give radiotherapy. The tumor is there, it will damage the hypothalamus. Radiation is going to damage the hypothalamus. Kurdistani child, 98, skiing in Kurdistan. Lady from Libya with this huge thing, almost lost her vision, complete cure. There's no floor of the hypothalamus, no floor of the third ventricle. Hypothalamus is pushed away. This man from, I think, Yemen, with this tumor and postoperative. And this tumor here from Sudan, I believe, yes, and his postoperative. So it's not one case I'm bragging about. This is philosophy. This is a school of thought, which I learned, and I'm keeping it. This 24-year-old, this is recent. Look at this extensive craniopharyngioma. Look at this. So we operated upon him, and it was really stuck to the optic apparatus. So that's why I chose to give him radiotherapy. Is it right, Dr. Sami? Yeah, you have given him radiotherapy recently, postoperatively. If you feel that they are stuck, better give radiotherapy immediately. And this is him. And again, this is the story of my life. This little boy of 3, in 2000, radical excision, no radiotherapy, no Umayya reservoir, no nonsense, and 20 years later. Let's see one film of how we do surgery for a fresh case, and then we'll see how to do surgery for a recurrent case. This is the last case that I mentioned, the 24-year-old man with this extensive tumor. We are in between the two optic nerves. This fluid is nothing. The mediocre surgeon would be then looking at his assistant. You see, we did decompression of the optic nerves. Surgery is done. This is ridiculous. This is a crime. This fluid is nothing. You need to remove the capsule, which is causing this discommission of fluids.
One comment about the fluid.
Yeah.
In fluid, if the surgeon is really not aware, you look like pus.
Absolutely.
Because the squamous cells, when they generate,
They
look like pus.
Yes.
So he will have an impression to the pathologist that
We have done an abscess. Yes.
And this is very important to compare to the neurosurgeon. Not everything that looks like a pus is a pus.
Absolutely. So this is the left optic nerve, the right optic nerve is there, the chiasm is here, the tumor is here, and it is here, and it is everywhere. You have to attack it every aspect, because this is a 24-year-old man. His destiny is in your hands. His future is in your hands. If he's your child, if he's your daughter or son, you would love that the surgeon there do his best, and not to be coward and ignorant and just take the fluid out and then send for radiotherapy. When I was operating, the father and the mother is in my mind. They are waiting outside, counting the minutes and seconds. waiting for some news about their child. You have to give them good news by being persistent, by being really educated. So this is the bread and butter. This is the capsule of the tumor that I'm after, not the fluid. By putting Umayya reservoir, they are just evacuating on the fluid, and the tube is gonna clog by this thick secretion. Revision of Umayya reservoir, shunt, revision of shunt, and so on and so forth. This is the carotid here on the left side. So this tumor is really adherent, more adherent than usual. Now, I'm not going to be courageous on the expense of the patient. If I find that radical excision is going to damage my patient, I stop. But I'm there, I'm aggressive. I want to remove every ion of it. This is a fight between me and the monster, and I have to win for the sake of the patient. Here is the stalk. Adherent to the stalk. Easy to cut it? No. If I can take the tumor off the stalk, I would do that, especially in a child. And this is a disease of children. So optic nerve, chiasm, I am in between. I found the stalk, and I want to remove the tumor. It's a giant tumor. You have seen the images. And actually, when he came, his vision was lost in the left eye. Now, after surgery, it's improving. Is it not, Sami? It is improving after surgery. This is what they leave behind after evacuation of the cyst. They have done nothing. The stupid mentor would be looking in the theater and say to his residents, see, we have decompressed the nerves. It's enough. I hope the residents are listening, and I hope that they will recognize their stupid mentors.
So those kinds of residents won't bother to educate themselves by this.
Absolutely. Now it is the tumor that is attached to the stalk. I'm trying to remove every ion of it if I can. If the stalk is tumorous, I excise it. But if it is attached, I try my best to preserve it. Okay. I think the message is clear. Yes. So what's the morbidity in my series of those cases? I have my share of complications, because if I'm doing surgery, I would have complications. Most of the complications are subdural hygroma and hydrocephalus. Again, hydrocephalus is for the same reason why they metastasize through CSF. These are my complications in numbers. And I always refer to this, psychological symptoms. These patients, after surgery, they see objects, they imagine objects, and they talk to them. You go away, go, seeing animals, and mostly green elephants and green monkeys. 2 mortalities, 2 patients died in my hands after surgery. And when we say surgical mortality, it is the first day, the first week, the first month. Any mortality within the first month is per-operative mortality. One patient I inherited from another Arab country who had surgery, but it's, of course, it recurred, it did not recur. So the tumor is still the same. We removed it completely. He died on the 7th postoperative day. Obesity. Obesity is a problem in carniopharyngiomas. Everybody is afraid of obesity. You may have the obesity pre-operative. So the classical teaching for medical students, if you see a young, intelligent child, 8, 10 years, who's plump and intelligent, think of carniopharyngiomas. So they can be obese pre-operative because of the lesion itself. Post-operative, if they develop obesity, usually it will subside, especially if you do radical excision. So this is before, this is not mine, this is before surgery. I think she was 20 years old, and now she's 32. So obese. In my series, I found that obesity happens in children in the first 6 months, 1 year, and then it gradually disappears. This child, obese, and then obesity started to disappear. So I'm not afraid of obesity to achieve radical excision. In fact, I tell the parents, listen, I want to go in and remove the tumor completely. You will see that your child will get obese, but it will recover on its own. This little girl, obese, and then back. No recurrence. And there's no floor of the hypothalamus. It is there, but it's pushed. So different children getting obese and then disappears. I did not notice this in adults. Adults do not show this obesity at all, in spite of doing radical excision. So what is the recurrence in my cases? And those when I did total radical excision, which is 84, mind you, 84 out of 102. It's a big number, but why did I fail? Because I couldn't. The recurrence was 11, while in those I did subtotal resection, the recurrence was higher. So I classify these cases. These are the cases which recurred, the collection. I classify them into my personal cases, which I did and they recurred, or the cases that was referred from other centers. Again, remember that this is not recurrence. This is a stupid, mediocre surgeon taking just a small piece and send the patient for radiotherapy. So the recurrent cases from other centers, 9-year-old, beautiful boy with this tumor. What did they do at St. Elsewhere? We don't want to name hospitals. Shunt. Damage the brain, shunt, send for radiotherapy. What more disasters do you want? So he was referred here to Jordan for radiosurgery or radiotherapy. We did not accept this. We cannot give this radiation at all. So we went in and removed the tumor completely. And here he is after follow-up. That's the boy. If this was my child, I would love to be referring him to a neurosurgeon, not a mediocre resident or surgeon. 25-year-old male patient, craniotomy, shunt for this. They evacuated the cyst, they put a shunt, hooray, hooray. We did radical excision, follow-up, he's well. Lady from Bahrain, 73-year-old lady, went in, recurrent, no, it was residual, it was not done properly. And on doing this, they caused damage to the internal carotid artery, causing aneurysm. So she was actually referring for aneurysm obliteration, not for surgery. We closed the aneurysm and we took the tumor out. Again, 25-year-old patient with this tumor extending from foramen of Monroe till foramen magnum. They attempted surgery but failed. So this is the redo surgery. Still, optic nerve, chiasma, tract, carotid artery, middle cerebral, anterior cerebral, basilar artery. You can see the coloration of the tissues not virgin. The cases in my series, where I've done radical excision and they recurred. So this is a young girl of 3. I removed the tumor completely in 2005. She came from West Bank, from Palestine. She was lost for follow-up 2007. After 2 years, she came with this huge recurrence. How come? I have done radical excision. This is the challenge, that when you do radical excision, they may come back again. So what about if you leave something? So what do you do? Radiotherapy, gamma knife? No, you go again and remove the tumor, which we did. And this is her follow-up. And look at her, beautiful young lady. 61-year-old man from Jordan with this tumor, which I removed completely. And that's him. 3 years later, recurrence. Radiotherapy? No. Surgery, and we followed him, and he's doing well. This is boy from Syria, giant carniopharyngioma. We did radical excision, and 3 years later, recurrence, radical excision. And here he is. This is from Sudan. This girl, 8-year-old, I operated upon her in the year 2000. Radical excision. 2002, still going, doing well. 2004, recurrence. What should I do? Radical excision again. 2008, major recurrence. I offered third surgery, the family refused. Another patient with this tumor, and you can see shunt. This is from Sudan. Shunt. And shunt for one ventricle, the other ventricle is still dilated. But this is what they know. This is what they were trained to do, a shunt, which is a stupid surgery to do. We did radical excision. 4 years later, recurrence. And what did we do? We did excision. I will show you different. Okay. So now we'll see a film for redo, for recurrent case. You will say, oh, adhesions and so on and so forth. It is difficult to start with, so what about redo? It is going to be hell. Yes, it's going to be hell, but you have to preserve. So here we are trying to remove the adhesions, identify structures. Indeed, there are a lot of adhesions, but by being perseverant, you will remove the tumor. Again, this is the chiasm, the tract. We are going into the lamina terminalis, which is the anterior wall of the third ventricle. So here you can see that the stalk is tumorous. I don't hesitate, I remove it. Especially when I have a good endocrinologist with me, like Dr. Mohammed Juma, I have no fear of good management. It is a group of people. This patient was operated upon here in Farah Hospital, and with good anesthetist who knows well what's happening, with good endocrinologist with me, I have no fear of operating on these patients. So I thank Dr. Mohammed Juma and Dr. Abu Aisha. So this is the challenge of this child from Sudan. So you can find the plane of cleavage, but if you don't want to learn, don't be stupid and refer for radiotherapy without trying to remove the tumor. So most of the time you will find a good plane of cleavage, even in recurrent cases. This is the basilar artery now. Okay. So the message here is that even if you have recurrence, surgery is much, much better than doing anything. Leave radiotherapy as a palliative treatment till the end. If in cases that I've seen, it is stuck and I'm feeling that it may recur, I would refer for radiotherapy. So this is the final post-operative. And this is the beautiful child from Sudan. So are there criteria for recurrence? What are the cases that recur? There are factors that affect recurrence. Adamantinoma, the recurrent rate is much higher than in papillary type. Papillary type is in the adults, adamantinoma in children. So recurrence in children is higher. Brain invasion, sometimes really they are invading. Incomplete surgical excision, like we see in mediocre surgery. Tumor size large is another cause, and high Ki-67. These are the criteria for recurrence, but the anatomy and extent of the tumor dictates the approach of excision. And with this, I finish and thank you. Any questions, comments, please?
To re-emphasize the point, first the injection of the craniopharyngioma site. Now, when you look at the injection literature of craniopharyngioma, you have to always bear in mind that by injecting, you are Xing the cyst, emptying the cyst, and then following up and injecting something that probably does not work. And when you look at stability of something over the lease of time, you always have to remember that you are actually evacuating the cysts regularly, and therefore spuriously controlling the tumor by evacuating it regularly. You're actually not doing anything to the tumor itself. The second point is emphasizing that there's absolutely nothing benign about a benign brain tumor, because it's the location of the brain tumor that's going to kill the patient. Malignant transformation is extremely rare, but the benign nature of the tumor itself is irrelevant given the location and important structure. So there's really nothing benign about a benign brain lesion. Third thing, and we continue to hammer this point again and again, radiosurgery, stereotactic radiotherapy with no tissue diagnosis and no attempt at complete excision is a crime, not only because the best chance of controlling craniopharyngioma from a medical oncological perspective is the first time around, and even a recurrent craniopharyngioma is the second time around, is because what you would miss by assuming that this craniopharyngioma from lesions that would have actually looked like craniopharyngioma. So missing things like pituitary adenomas without bothering to treat them properly, meningiomas where the treatment of choice would have been surgery itself, but germinomas where the treatment would have been be that secondary germinomas or primary CNS germ cell tumors, where the treatment after obtaining diagnosis would be curative, even if they're metastatic from elsewhere, and the mainstay would be platinum-based chemotherapy with curative intent, even if this is CNS metastasis. Histiocytic sarcoma is not something to be missed in this location. Thank you. Now, histiocytosis is something that recurrently would happen on this site and would have been missed like that. Lymphoma in this site, be that as a secondary involvement by systemic lymphoma or as a primary involvement of CNS, which would be primary CNS lymphoma, which will be the reason why we continue hammering this every week, is because the treatment is radically different. In this case, if it's primary, the treatment of choice would be methotrexate at high enough doses to delay radiotherapy as much as possible. Sarcoid that would have been buried as evidence by radiotherapy, and then the patient would die in a mysterious manner because you missed that. Plasmacytoma, where if it's truly primary, that there is no evidence of multiple myeloma in the bone marrow, etc., radiotherapy would be the treatment of choice and would be curative in most cases. Mets, because nobody bothered to examine the patient properly, and by radiating the met and forgetting the primary, the patient would succumb to the disease. These are actual cases. This is not hypothetical scenarios, and those patients would have been labeled as craniopharyngiomas and would have been subjected to stereotactic radiotherapy and then died under mysterious circumstances. And that's not necessarily because of recurrence of the craniopharyngioma. It's because of succumbing to a renal disease that was never diagnosed to start.
Thank you. Any comments, any questions? Please.
First of all, thank you for your great presentation. Yeah, very beautiful work, and definitely be added to the.
Dr. Rami Darwaz is a neurosurgeon. He's from West Bank, Palestine, and he trained here with us, and he went also to China where he had further training. He's joining us for 6 months of training in skull-based surgery.
Yes, I have just one question, since you mentioned in your series the adults did not have obesity complication while the children did. Why is that?
I have no answer to this. I've been asked this question in every conference I go, because my cases are the only cases where obesity issue is addressed. Nobody has mentioned this in the literature. So whenever I go, I present these cases, and I'm a frequent presenter in craniophryngiomas sessions. The answer is I don't know why. Hypothalamus is the same for a child or an adult. Please.
I have, regarding obesity, particularly in children, a lot of them, they do have coexistent apoptosis nigricans and insulin resistance. It is not related to surgery per se. It is not related to the damage of hypothalamus, which control that. A lot of children, particularly Sudanese, yes, definitely apoptosis nigricans with insulin resistance. And those children, it is very difficult to treat, even without surgery. Insulin resistance, it is very common. They tend to love sweets, carbohydrate, carbs, and it is very difficult to reduce body weight.
أشكرك كعهدك دائما تعطينا الأجمل والأعرق في هذه الجراحة. أنت كجراح رائد، هل يخالجك أحيانا الندم لأنك كنت أول من أحضر الجاما نايف في هذا البلد فسهلت على المديوكر عملهم؟
The flat answer to this, yes, I feel guilty. Because when I was a part of this project, the answer was that we'll bring something that will take us the level up, i.e. good centers would have all kinds of modalities, so why should not we have the same? So I was under the impression that this is a scientific way of improving that is going to be used in certain purposes. And then people who financed this project wanted this machine to treat all brain tumors. They just wanted money. They were not after scientific progress. So at the end of the day, it has fallen, gamma knife in general, in the whole world, has fallen in the hands of mediocre surgeons who do not know anything about surgery, and who do and treat all cases with radiation. So yes, I feel guilty. See you next week.
بدعتي كمان نفس السؤال كان عندي لك. الحمد لله. Thank you very much. ما فيش. عرفنا خلي على الله. صح. في دكتور معكم كان بنته في انيميا وشح كمان نص الليل. دكتور يشتغل معك.
دكتور نصر.
شو طلع
عندها نيوروبلاستوما سوبرين.
انا عاد ضربت له اياه، كنت خايف، قلت له انا خايف من شيء. لا نيوروبلاستوما سوري. شلون هو موجود؟
No, can't hear.
Okay, can you hear me, Dr. Sabea?
Yes, I can hear you.
Yeah, great. Thank you very much. Another excellent presentation, clear, well illustrated. Let's first go around with the panelists and meet them one by one. We had 11 at one point, but as you know, people come and go. Marco, could you please?
I'm a neurosurgeon from Italy, northern part of Italy. I appreciate a lot your presentation, very clear, and I appreciate a lot how you highlighted the role of surgery that is still active and important role there. Radiosurgery and gamma knife, even in this case, when we talk about children, the role of surgery is, in this case, I guess, is mandatory. So thank you very much for your presentation.
Thank you very much. Thank you.
Okay, very good. We have Abdullah or Anas. Do you have any comments or questions for Dr. Sabaya? Hi, Abdullah.
Hello, John. Thank you so much.
Welcome back. Welcome back.
Thank you so much. I listened to a fantastic presentation by Prof. It's nice. I actually posted a comment. I guess, Professor John, you must have read the comment, but probably let me read it out. Sure. Thank you so much for this expose and the fantastic results. The results have shown that nobody is infallible. Prof, sir, you are a bit too abusive in your language in the use of stupid and mediocre. Even the word experts that you mentioned in your presentation that emphasized complete excision must have tried other options that you typically condemned with strong language. A senior of mine said that you can never be a hero in the field of medicine and neurosurgery, in particular, as everything is still evolving. That is why the emphasis on evidence-based medicine now. So I enjoyed every aspect of your presentation and only wish to be an expert like you. Thank you.
Thank you very much.
I hope I'm not too strong in my language as well. I enjoyed every, and some of us that are very junior in this field, when you kept on using the word stupid and mediocre, I was a bit thrown back that if we attempt anything that probably the result doesn't come out well, the condemnation will be too strong. Yeah, so I think I just say I should have that comment passed across. Thank you so much for the presentation.
Okay, thanks for your feedback. Abdullah, could you please introduce yourself? Where are you from and what do you do, etc.?
Okay, yes, I'm Abdullah Jimo. I'm an associate professor of neurosurgery from Nigeria. I'm currently in Morocco, Rabat, doing a fellowship in stereotaxy, gamma knife, and deep brain stimulation, functional neurosurgery generally. Yes.
Very good. Welcome. You're always welcome. Anas, do you have any comments or questions? Are you there, Anas? I saw you there a little while back. Let me unmute him. I think, well, he may have stepped away. Well, Dr. Melham, are you there? Oh, there is Anas. Okay, go ahead, Anas. Go ahead.
Hello, Professor Ibrahim. Thank you for interesting, but I want to say that the word stupid is a little word, but because there is a surgeon, they did really a crime when the surgeon used the shunt to decompress the intracranial pressure without removal the tumor tissue itself. It's really a crime on the word stupid is too little to describe this procedure.
Absolutely.
I want to emphasize that everything was wonderful. On the results reveal that the skills is very proceeded. I have only one question. How can the surgeon intraoperative determine the pituitary stalk? Is this from color for the anatomy for the attachment to the chiasm? It seems though from the color. Right?
Yeah, it's various aspects. It's the anatomical knowledge of where is the stalk. Okay. You have read your images properly. You are not counting on the report of the radiologists. You're counting your information of radiology yourself as a surgeon. So you determine where the stalk would be, and you would look for it. You will see it. It's full of blood vessels. It is tubular. It's reddish in color, so you can discriminate it from the tumor. If it cannot be discriminated, if it is really part of the tumor, then remove it. It's a tumor. It's no more a stalk. But if I can preserve it, I would preserve it, no doubt about that. I would go back to the question of the hydrocephalus. It is a crime that if you don't know to do craniopharyngioma surgery, refer the cases for somebody who knows. There must be somebody in your department, in your country, in your city who knows. Don't be selfish and don't be criminal and put a shunt. They say, oh, it was emergency in the middle of the night. I say, rubbish, because you can put an external drain and save the patient's life until you send them to somewhere else. To put double shunt on both sides and connect them with Y connection is a double crime. But this is practiced every day, and my duty in life is to expose these practices for the residents, for the mentors who teach them the wrong ideas, and saying that we have decompressed the tumor, putting Omeya reservoir, and so on and so forth.
Thank you very much.
It's a pleasure.
Okay, very good. We'll wrap it up now. Doctor, what's the topic next week, Dr. Abraham? Do you have one yet?
I will definitely tell you tomorrow, because I have to look into the availability of these subjects. But
very good. Thank you very much for Dr.
Pleasure.
Thank all the panelists for coming. Bye-bye.